Hey, so welcome to Chapter 14 lecture. This is all about disorders in immunity, also known as immunopathology, which is just a word that means the study of diseases of the immune system. Now, the immune system is meant to protect us, but it can also backfire and harm us. And the two sort of arms of immunopathology are those where the immune system is underreactive, or understimulated, and we say that people are immunocompromised in that situation, or where the immune system is overreactive or overstimulated, and then we call these hypersensitivities. So the first category we're going to talk about are these hypersensitivities. There's actually 4 types of hypersensitivity, and this slide is kind of busy and detailed, and I'll come back to it to sort of summarize after we learn about these 4 different types of hypersensitivities, but things to note is they are typed, type 1, type 2, type 3, type 4, and they each have sort of a name that goes with that type. And they have different mechanisms that are involved. So type 1 is involved with a lot of IgE antibodies, is mediated by IgE antibodies, but type 2 is mediated by a different set of antibodies, and type 4 is actually mediated by T cells. So there's different parts of the immune system that are involved in each of these types of hypersensitivity. And we'll talk about some examples of each of these as well. Alrighty, so type 1 allergic reactions we'll spend the most time on. These are, the type 1 hypersensitivities are what we classically know as allergies or allergic reactions. And an allergy is just, it's an overreactive response or an oversensitive response of the immune system to something that it recognizes as foreign, and even though it's harmless, it recognizes it as harmful and starts trying to attack it. Type 1 allergic reactions are very common. 10 to 30% of the population experience them in some form or fashion. And they can develop at different ages. There are some that can develop very early on. Eczema, inflammatory skin reaction, can start even as soon as newborns. When infants start eating foods, getting introduced to real foods, they can develop or start showing food allergies. Rhinitis, we'll talk about, that means inflammation of the nose. So basically hay fever, when you get all, your nose is runny and your eyes are itchy and stuff from pollen. And asthma, these are some very common types of allergies. So 2 terms to know with allergy. Most of the time when we're talking about allergies and allergic reactions, we're talking about atopy or atopic reactions. So like hay fever, it's localized to the nasal passages, to the respiratory system. Eczema, localized to an area of the skin. So atopic allergies happen in a localized area, whereas anaphylaxis is a systemic, full body-wide response to an allergen, and it can be very serious. It can be fatal. So people who have mild allergies, we say they have atopy. People who have very severe reactions have anaphylaxis. So the weird thing about allergies is they can develop either early on in childhood. Some allergies don't develop until later on in adulthood. I had a friend whose mom was a gardener. She gardened for years and was out in her garden one day and got stung by a bee, probably the 50th bee sting she ever had, and all of a sudden started swelling up and having an anaphylactic reaction and almost died. So it could happen at any time. You can become allergic to something. You can also outgrow allergies. So the allergic response is still very poorly understood by immunologists. Why it happens in some people and not others is not very clear. And although we know that people can outgrow allergies, we're only sort of starting to understand how we can turn them off in people. We don't really know how to prevent them, but there's definitely theories, and we'll talk about them. All right, so what we do know is that people who have allergies in their family are more likely to have allergies. We call that a heritable susceptibility. All right, so if your parents are allergic to, if your dad's allergic to penicillin and your mom is allergic to peanuts, it's pretty likely that you're going to be allergic to something, but you might not be allergic to peanuts or penicillin. So you don't inherit a specific allergy, but if your parents have allergies, you are likely to be allergic to something. You are likely to inherit a susceptibility to allergy. One of the theories for why we have allergies is, and we have an increase in allergies, particularly in developed countries, is something called the hygiene hypothesis. This idea that we are actually too clean, that we are not exposed to enough pathogens. If you remember that video that we watched about the sort of cartoony video about the role of microbes in the human microbiome, one of their roles is to train our immune system. So if we are not introducing our immune system to enough of these right harmless microbes, we are possibly not training our immune systems very well. And there is a correlation between kids who are raised on farms or with lots of pets and exposed to lots of animals. They tend to have fewer allergies than people who live in developed apartment buildings, no pets, no animal exposure. So just the more kind of dirt and environmental things that you seem to be exposed to actually seem to reduce your risk for allergies. They've also done a study where they showed that parents who, when they drop the pacifier, don't wash it, or like just wash it by putting it in their own mouth, all right, and give it to the baby, that those babies have less allergies than parents who only put sterilized bottles and pacifiers in their kid's mouth. So it's this weird idea that germs actually protect us by helping us train our immune system. Another one, pathogen that I'm going to point to specifically, so we get a lot of bacterial and virus exposure still in developed countries. What we're really lacking in developed countries are helminths, worm infections. And undeveloped countries or developing countries still suffer a lot of worm infections, and they hardly have any autoimmune diseases. So there's this idea that, and it's well known in the deep field of immunology, that helminths, worm infections, actually stimulate a whole different arm of the immune system than bacteria and viruses do, and that somehow having this, maybe this imbalance in these different arms of the immune system is causing the immune system to not work properly and therefore give us these over-exaggerated responses, allergies. This is just a graphic from an article in Nature Reviews, sort of showing this hygiene hypothesis, that developing countries we have, or not we're not a developing country, they tend to have large family size. They tend to live in rural areas with lots of livestock. They've got a high risk of helminth disease, maybe less sanitation, all right, and they tend to have very few allergic reactions versus westernized developed countries, which have smaller family sizes, urban homes, high antibiotic use, so we cut down a lot of our microflora. We don't have exposure to many helminth infections, and we have lots of sanitation, and we see more allergic disorders and more autoimmune diseases. So suggesting that there's definitely a correlation. Whether any of these things contribute to the causation of allergies, we are still unsure. Genes, though, do play a role as well, but genes and environment always sort of together play a role in phenotype. So allergens. Allergens can come in many different forms. Remember, allergens are a type of antigen, so they tend to be complex. They tend to be proteins, and they elicit this very specialized immune response. So there's different portals of entry for allergens. There are some that are skin contact is enough. So a lot of plants, poisonous plants, like poison ivy, the oil in the poison ivy is actually just a very common allergen, and the reaction that it induces is an allergic reaction. Some people are allergic to latex, or people who are allergic to animal dander. That can cause them to be itchy on their skin, cause a red rash. All right, the dander can also be inhaled. Inhalation is another form of portal of entry. Pollen, also a common inhaled allergen. You can have allergens that are ingested, food like nuts and shellfish are very common allergens, food allergens. Medications, drugs, can act as allergens. Now, medications are usually not proteins, so the medication itself is not complex enough to be an antigen or an allergen. But what can happen with these medications is they can act as haptens. That means they basically fuse to a protein. They can become complexed with proteins in your blood, like albumin, and then together that fusion makes it big and complex enough for the immune system to recognize it. So that's how drugs end up becoming allergens. And then finally, there are ones that are injected. They can be injected. Bee venom is the classic injected allergen. So let's talk about the mechanism. What's actually happening in the body during a type 1 allergic reaction or type 1 hypersensitivity, right? In all cases of all of these types of all allergic reactions, all right, it's a sort of two-step process. A lot of times people think that they can be they're afraid to try something because they don't know if they're going to be allergic to it. You're not allergic to anything before you try it. Allergies must come from exposure. The first time you have that substance, whether it's a food or something that you touch, that is the sensitization step. Your body, the first time that you see it, or maybe it's the 10th time or the 100th time, at one of those exposures, your body decides that that substance is foreign. It's recognized by B cells, and the B cells start making IgE antibodies. And then the IgE antibodies recognize that antigen the next time you're exposed to it. So any subsequent exposure, you have an allergic reaction due to those IgE antibodies. And I'll show you what happens, how those IgE antibodies work on this slide here. All right, so it's a little busy, but I'll walk you through it. So the first step on the left side here, you get some sensitizing dose, whether it be peanut protein or latex on your skin. Okay, it goes in to your body, and it's recognized by B cells. Remember, B cells can actually be antigen presenters, and they actually they recognize these antigens and present it to a T helper cell, and the T helper cell then activates that B cell to start making IgE antibodies specifically. All right, so now the IgE antibodies go and they bind, they basically cover these specialized white blood cells. There's a type of basophil that are called mast cells. And these granules inside the mast cells are full of cytokines, especially histamine. And these antibodies, the IgE, basically the mast cells have a receptor for the IgE antibodies. So if there's IgE antibodies, they bind to the surface of these mast cells, and then any subsequent exposure to that allergen activates, it binds to these IgE antibodies on the mast cells, and it triggers the mast cells to release all of those cytokines, those granules. And all of those cytokines, those chemicals, result in all of the phenotypes or the presentation of allergic reactions. So some of those key cytokines that come out of those mast cells, histamine being the most important one, and histamine does two really important things. It can constrict the bronchioles and the intestines, which can cause issues with breathing, and also can cause issues with digestion. Sometimes in little kids, they don't get your typical like wheal and flare redness rashes with an allergic reaction. Sometimes they'll have stomach problems, and that still can be due to histamine's effect on the body. But the classic signs of histamine are those redness that's caused by dilation of blood vessels. So the dilation of blood vessels causes redness and edema or swelling. And histamine also makes you very itchy. It stimulates nerves and gives you that sensation of itching. So that's why for a lot of allergies you take antihistamines, because they combat the effects of histamine, which is a major cytokine in allergies. Leukotriene is another important one. This is one that's really important in anaphylaxis because it causes a slow constriction of the bronchioles in the lungs, which makes it harder and harder to breathe, and that's problematic. And then and so if somebody takes an inhaler, has an inhaler, or takes asthma medication, fast acting, like when you take an inhaler, the way that those work is basically they counteract the leukotriene, they cause dilation of the bronchioles. And then the third one that I want you to know are the prostaglandins. And these are the ones, one of the notable things that prostaglandins cause is pain, the sensation of pain, the molecules that stimulate pain receptors. And so another thing that we take sometimes for allergies are NSAIDs, non-steroidal anti-inflammatory drugs, because they typically block the formation of prostaglandins. So a lot of the classic drugs, over-the-counter medications that you take for allergies work actively to counteract the effects of one of these 3 cytokines that are produced by those mast cells when they are triggered to release. This is a slide just showing you more graphically, picture-wise, how each of those different cytokines works. So here's those cytokines. Remember the granules that were released by those mast cells. The prostaglandin leads to pain, is the key thing with prostaglandins. Leukotrienes cause constriction of the bronchioles, so it makes it very hard to breathe, hence needing like an inhaler. And then histamine and a couple of other important cytokines, but histamine in particular causes the swelling, the blood vessel dilation that leads to swelling and itching and redness, and also blood vessel dilation in the nose and eyes leads to like fluid leakage, so you get a runny nose and runny eyes, redness of your eyes, and it can also cause intestinal issues, diarrhea, vomiting, etc. Okay, so some very common types of allergies, of atopic reactions, sort of localized reactions, are what we commonly call hay fever, but medically is called allergic rhinitis or allergic inflammation of the nose, right? And this is usually seasonal, but can be year-round, depending on what you are allergic to. So if allergens are commonly found indoors, like dust, then they could be year-round. But if your key allergens are pollen or things outside, then that can be more seasonal. Asthma is a sort of more severe form of allergic rhinitis. It involves bronchoconstriction, so not, it's still respiratory, I guess is what I'm trying to get at, but it's further down, it's lower in the respiratory system, in the bronchioles, and they start to constrict. And so it's a little bit more, it's more severe than hay fever because it can have more severe pathophysiology anatomically. And then eczema is another very common atopic disease. It's inflammation of the skin, an allergic reaction on the skin. And it's why putting lotion on eczema is really unsuccessful at treating it, because it's not just dry skin. A lot of people think that it's just dry and you need to just moisturize it, but that won't help. You actually need to treat it with corticosteroids, hydrocortisone, something that'll actually dampen inflammation, not something that's going to moisturize it. And moisturizers a lot of time can cause even an increase or exacerbation of the inflammation. Another common types of type 1 allergic responses are food allergies and drug allergies. So these are ingested. There is a difference. I like to really stress this in a lot of classes, that food allergy is different than a food intolerance. So milk is a classic example here. There are people who are allergic to milk, meaning they are allergic to the casein protein, an important protein in milk and dairy products, and they cannot eat any milk or dairy product. They can't eat anything that's even has milk as an ingredient in like bread, because that protein can elicit an allergic reaction. Whether it's a mild allergic reaction or anaphylaxis varies in different individuals. This is very different than someone who is lactose intolerant. People who are lactose intolerant can't eat milk because they can't digest lactose. So it's a totally different chemical component of the milk that's causing problems in those two cases. And lactose intolerance has nothing to do with the immune system. It doesn't elicit an immune reaction. It's just an ingredient in the milk that your body, your intestines can't digest properly, and it ends up giving you diarrhea and abdominal cramping, which is very different than a milk allergy. So I used to get mad at my kids because they had certain foods they didn't like when they were little. Like one of them didn't like potatoes or anything made with potatoes, and he would tell people he was allergic to potatoes. And I was like, you can't say that, because allergies they're a very serious thing. They need to be taken seriously. You can't just say you're allergic to something just because you don't like it. Same thing, you shouldn't say you're allergic to something if you're intolerant to it. There's lots of foods that tend to be common allergens: peanuts, fish, two really common ones. But I've heard people who are allergic to all kinds of things. The symptoms can range from abdominal pain and cramping and vomiting that may look something like an intolerance but aren't. Or it can cause a rash and hives, swelling of the mouth and tongue and throat, or in some cases can even cause anaphylaxis. Now, drug allergies are similar. People who take, whether the drug is ingested or injected or put on the skin topically, all right, if you're allergic to it, you're going to be allergic no matter what the route of administration. About 5 to 10% of people are actually allergic to some type of medication, oftentimes antibiotics. Again, antibiotics are taken very regularly. They're given to kids throughout their lives, and remember, to become allergic to something, you have to be exposed to it. So the more times we're exposing people to something like penicillin or amoxicillin, if everyone's taken it at some point, the likelihood that some people are going to develop an allergy is just very realistic. So remember, drugs are too small as molecules. They're not complex enough to serve as antigens by themselves. But what they do is they tend to fuse with other proteins in the body, maybe when the liver processes them, and that makes them more complex and makes them antigenic or allergenic. And again, the symptoms can range from like a rash or swelling or hives to anaphylaxis. So what is anaphylaxis? Anaphylaxis is a systemic reaction where basically, instead of histamine being released like in a small patch on your skin as an eczema, or my friend in college who's allergic to apples, he ate like a piece of fruit leather that was like strawberry flavored, but he didn't realize it had apples in it as well, and his tongue got really swollen and his lips got kind of swollen. All right, those are still localized reactions, but had he had an anaphylactic reaction, it would be histamine not just being released in his mouth, but throughout his body, in his blood, which can basically cause swelling and inflammation of the internal organs, particularly of particular importance, the respiratory and cardiovascular system. So typically, anaphylactic reactions are more common in allergens that are injected. So like if you were allergic to penicillin and you got injected with penicillin, that wouldn't be good. Or bee venom tends to have a higher rate of anaphylaxis. But also there are people who have anaphylactic reactions to ingested food items. This is a short video I'm going to show you about what happens on the tissue level, how the massive release of histamine and other cytokines cause disruptions in the circulatory and respiratory system that can be fatal very quickly.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct.
Anaphylaxis is a systemic reaction that can occur when a patient who is allergic comes into contact with the allergen they have been sensitized to. Clinical symptoms may be mild, moderate, severe, protracted, or biphasic. The allergic response begins with exposure. As antigen molecules enter the bloodstream, they interact with IgE antibodies, bound to mast cells and basophils. This union of antigen and antibody produces a complex sequence of intracellular biochemical events in the form of a cascade. A signal sent through the IgE antibody to the cell's interior begins the sequential activation of a series of enzymes. This leads to the influx of calcium into the cell and the fusion of granules with the cell's external membrane. The result is degranulation, with the release of histamine and other chemical mediators into the extracellular space. These mediators flow through the body and bind to receptor sites at target organs, producing physiologic effects such as vasodilation and increased vascular permeability. In the lungs, histamine produces smooth muscle contraction, which causes obstruction, wheezing, and shortness of breath. A combination of mechanisms results in myocardial depression. To overcome these life-threatening events, epinephrine must be self-administered without delay. Upon injection, epinephrine works rapidly at organ sites to counter the effects of chemical mediators, acting to constrict blood vessels and reduce vascular permeability, relax smooth muscles of the airway, and stimulate the heart rate. This generally reverses the most dangerous effects of an anaphylactic reaction, allowing time for transport to an emergency center for full professional care. However, in some cases, the continued flow of mediators prolongs the pathophysiological effects or produces a relapse of the anaphylactic state. A single dose of epinephrine is not enough to reverse reactions in these cases. Patients should be advised that if symptoms have not improved within about 5 minutes after the first injection, a second dose is indicated. A second dose of epinephrine may be essential to adequately counter the anaphylactic reaction. The understanding of anaphylaxis as a continuum, with the potential for a severe, protracted, or biphasic event developing after the initial phase, underscores the need for 2 doses of epinephrine to be readily available for patients at risk.
All right, so it doesn't show you how to administer epinephrine, but epinephrine is a fast-acting first line of treatment for someone experiencing anaphylaxis. So it's important people who have severe allergies carry an EpiPen with them. But it's also important to know that after giving a dose of epinephrine, it doesn't mean that the person is better and you fix the situation. You still need to get them medical care. It just buys you time to get them that medical care. Alrighty, so how do we diagnose allergies? A lot of people know this, they've been through it or they have family members that have been through it. So a very common form of testing is through skin testing, where in this picture here of this person's arm, they basically poke you with like, I don't know, hundreds, dozens or hundreds even of different needles. They can do it on the arm, they can do it on the leg, they can do it on your back. There's different areas of the body where they can do it. And then basically you come back a couple days later and they look for swelling. And if there's swelling at that site, then that means you're allergic to that particular substance. Another way to do it, and it's very uncomfortable, it's not fun. Blood tests is another way that you can test for allergies. Basically, they can do blood tests and look for specific IgEs, IgE to dog dander, IgE to oak pollen, I don't know. And so that's a blood test. It's generally more expensive, and it does require a blood draw, so it doesn't involve one needle, but it doesn't involve the multiple little pricks of your standard skin test. And then also not the discomfort of the itching and atopic responses that you have to the skin test itself. Treatments for allergies, some of them we've already talked about. So the first treatment is prophylaxis. In other words, try to avoid the allergen. Sometimes this is possible. If you're allergic to dogs, don't get a dog. If you are allergic to bees, try to avoid bees. Try not to anger bees. Don't go like bashing beehives or anything like that. But sometimes, you still get stung even despite your best efforts. And sometimes you can't avoid things like pollen. So if you can't avoid your allergens, you can take drugs that block some of those cytokines, like antihistamines, which block histamines, that helps with the redness and swelling and itching. NSAIDs, nonsteroidal anti-inflammatories, which help with the pain that's caused, they block the prostaglandins. And then corticosteroids are a class of drugs that just dampen different parts of the immune system. They dampen inflammation in general. A lot of times you can get these topically to put on like a rash. You can also use an EpiPen if somebody's having an anaphylactic reaction. An EpiPen, epinephrine, can it sort of counteracts some of the effects that a massive histamine reaction have. So histamine causes massive vasodilation, and epinephrine causes vasoconstriction, so it closes closes that permeability of the blood vessels, and it also helps to stimulate the heart contractions, etc. And then another treatment that's relatively new and practiced by some allergists, but not widely spread and widely practiced yet that I know of, are these what are called allergy vaccines or allergy shots, where basically you can take someone who has an allergy and you can slowly desensitize them to their allergen. So someone with a deadly peanut allergy, by giving them like really tiny doses of peanut over and over in like sort of then increasing amounts, you can actually like sort of get rid of that allergy. It's sort of based on the fact that some people naturally grow out and outgrow allergies. Their body just stops recognizing it as foreign. So sort of it's a way of training the body to see that allergen as normal. And it works, or at least it has worked for many people. And sometimes it doesn't maybe make the allergy go away entirely, but reduces the severity of it so that you don't have to live in fear of dying from eating peanuts, just of having hives from eating peanuts, which is an improvement in quality of life for a lot of people. So this is just a slide from the book that I like that shows these different treatments in graphic form. So if this is the steps in the allergic response, the antigen causes the first sensitization of antigen causes the production of antibodies, IgE antibodies by B cells. All right, those antibodies then bind to mast cells, and when the antigen comes back, it stimulates or activates these mast cells to degranulate and release cytokines like histamine, which can cause the blood vessels to dilate, redness, swelling, itching, other things. So you can avoid the antigen. You can take steroids to prevent the B cells from making those IgE antibodies. You can get injections of monoclonal antibodies, which I didn't go over. Don't worry about that. It's pretty uncommon. There's drugs that will actually prevent the mast cells from degranulating. And then there's, of course, your over-the-counter antihistamines and NSAIDs, which block the functions of a lot of these cytokines that are produced. So lots of different ways. So those are the type 1 allergic reactions. Again, the most common type of hypersensitivity response, type 1. Now we're going to talk about type 2, type 3, and type 4 hypersensitivities. Type 2 hypersensitivity are reactions that cause the lysis of foreign cells. And the classic example is during a blood transfusion with the wrong blood type. So if we look at the different blood types, we've got type A, type B, type AB, and type O. And I like these little cartoons because they show that type A is called that because these red blood cells have these A antigens. In this case, they're drawn as little red circles. Type B blood has B antigens, and here they're shown as little blue squares. People with type AB blood have both A and B antigens, and people with type O blood have no antigens, or they have these type O antigens that are so small, they basically have no antigens. Okay, so if somebody gets the wrong blood type, they will lyse those donor red blood cells. They'll recognize them as foreign, and lyse them. And this is mediated by antibodies. The wrong blood type is recognized by antibodies in the body that target those cells for destruction. The difference is that the antibodies are not IgE. They are IgM or IgG antibodies. I guess maybe write that on this slide. Antibody mediated, but specifically IgG, IgM or IgG antibodies. So another type of blood reaction that is a type 2 reaction, it can happen in pregnant women with another antigen on the blood called the Rh factor or the rhesus factor, or in some countries they call it the D antigen. And so you'll hear it different things. In Australia, I know they call it the D antigen. In the US, they mostly call it the Rh factor. I don't know what they call it in Canada, our closest neighboring country. So most people, when you have a blood type, A positive, O negative, all right, the positive negative part is referring to whether or not you have this D antigen. And most people do. Most blood types fall in the positive category. A positive, B positive, AB positive, and O positive make up about 85% of the population. So negative blood types are in the minority. And when you have a scenario where you have an Rh negative woman with an Rh positive partner, sperm donor, husband, boyfriend, whatever, then the developing fetus could be Rh positive. And if the fetus is Rh positive and the mother is Rh negative, it's fine during pregnancy. During the first pregnancy, all is well. But when that baby is born and the placenta is ripping away, so during the pregnancy, there's not a whole lot of cross-contamination of blood from the fetus to the mom, but there can be a little, but definitely during labor. A lot of the fetal cells enter the mom's circulation, including fetal blood cells. So you can see these little pluses starting to circulate throughout the mom. Well, what happens is then that sensitizes the mom. She becomes sensitized and recognizes those Rh antigens as foreign and makes a bunch of antibodies to them. This doesn't affect her daily life, but if she gets pregnant again, she now is full of all these anti-Rh antibodies that can cross through the placenta and start attacking the fetal blood cells. And this can kill the baby or cause a very, very severe anemia in the baby. So so women who where's my slide here? Okay, let's talk about it. So this is just another picture showing you this disease that forms in the baby. So in the first pregnancy, all right, some of those red blood cells end up getting into mom's circulation, and then she starts producing antibodies, all right, but this first baby can be born normal, but any Rh positive babies she's pregnant with after that will be attacked by her antibodies that she has now. The anti-Rh antibodies will move in through the placenta into the fetus and can cause erythroblastosis fetalis or hemolytic disease of the newborn, which can cause developmental issues, brain problems, cause jaundice, from anemia, congestive heart failure, so lots of problems, and it can be fatal. So in order to prevent this from happening, women who are Rh negative are automatically given a shot of RhoGAM late in their pregnancy, even if their partner is Rh negative, just out of total making sure that everything is safe, but especially if their partner is Rh positive and there's a chance that the fetus is Rh positive. All right, so when RhoGAM is given, RhoGAM is basically just anti-Rh antibodies. It's the same thing that the mom's body would produce, but it's a small dose of it. So what happens is they're given this shot of anti-Rh antibodies late in pregnancy, right before labor. I want to say somewhere in the 30-week range. It's definitely in the third trimester. Might even be more like 36 weeks. Maybe it's like 26 weeks. I can't remember. You guys probably know in your maternal nursing classes what week it's given. Not important for this class. What's important for this class is you know the mechanism of it. So these antibodies, what they do is they neutralize those fetal red blood cells that do get it into the mom's body. and then destroys them without sensitizing the mom's B cells so that she doesn't start making her own antibodies. So it's a small dose of antibodies that just neutralizes and destroys any fetal cells so that the mother does not get sensitized and does not start making her own anti-Rh antibodies. And this way, a mom who's Rh negative can continue to have Rh positive babies without risk of hemolytic disease of the newborn. So it does not have to be given if the fetus is Rh negative, but it usually will be. Alrighty, so that's type 2. Type 2 immune or hypersensitivities are going to be ones that recognize foreign cells and lyse them, mostly blood cells, red blood cells, whether they're A, B, O, positive or negative, if any of those groups are not a match. All right, type 3 hypersensitivity is much less common. They're similar to type 2 in the sense that they are involved with, or they're IgG mediated. So IgG antibodies are what causes them. So what happens in type 3 is you get what's called an immune complex reaction. In other words, it happens when you have like an injection of a large amount of antigen and then a whole bunch of antibody comes in and it just forms like this big glob of antibodies and antigen. AG stands for antigen, AB for antibody. So it's these big antigen-antibody complexes that then just kind of are heavy and sink and just deposit into the tissue, just causing a source of inflammation. So two types of type 3 hypersensitivities are the Arthus reaction, which can happen when you are getting injections of drugs or biologicals. And serum sickness can also happen when you are given injections like IV injections of hormones or drugs or serum or anything like that. Arthus reactions are usually localized to that site of injection, whereas serum sickness is a systemic injury. It can also cause organ failure or organ damage. What is similar about it is that it uses IgG, so it's similar to type 2 because it uses IgG or sometimes IgM or IgA. It's different from allergies, from type 1 allergic responses, which are the ones that use IgE. Another thing that's different about it is it requires a large dose of antigen, so like an injection of like a concentrated amount, not a tiny minuscule amount like somebody who licks a peanut and has an allergic reaction. And it's also slightly delayed, so it doesn't happen right away in a few minutes. It might take a few hours or sometimes a few days to show up. And that sort of connects it to our last type of hypersensitivity, the type 4 hypersensitivity, which is known as the delayed reaction, a delayed hypersensitivity. And this one takes often a couple of days, more than several hours, a couple of days for this one to show up. It's also different because it doesn't involve antibodies. It is cell-mediated. It involves T cells. And we see it most with transplant reaction. So if you're given foreign tissue from another person, then you can have your T cells can recognize that new kidney or new lung as not part of yourself and start attacking it. And remember, T cells are the immune cells that actually kill body cells, not bacterial cells. But it takes a couple of days for this to show up. Okay, so this little diagram here shows that the antigen comes in. It's recognized by antigen, those are some phagocytes that are eating it and then presenting antigen to T cells. And then the T cells release cytokines that cause all this inflammation, things, more white blood cells coming into the tissues, causing redness and swelling. All right, but it all takes some time for that to happen. Some classic type 4 delayed hypersensitivities. One is induced by the tuberculin protein. So the Mycobacterium tuberculosis is the bacteria that causes tuberculosis, and it produces a protein that causes a delayed hypersensitivity response if you have been exposed to tuberculosis before, like if you haven't. So a classic test for tuberculosis is called the tuberculin test, or sometimes it's called the Manteau test, or sometimes it's called the PPD test. All right, PPD stands for Purified Protein Derivative, I think, of tuberculin. And so they inject it subcutaneously right under the skin. And then you have to come back after a couple of days and they measure how much swelling there is. If there is swelling or a delayed hypersensitivity reaction, it means you have been exposed to Mycobacterium tuberculosis before. If you have a positive test, then they often ask you to get a chest x-ray to make sure that you don't actually have tuberculosis. Some types of contact dermatitis are delayed reactions. Poison ivy. You go out, you touch some poison ivy. It's usually not till the next day that you actually have a rash. So it doesn't give you that itchy rash right away like a mosquito bite does. You get a bite within a couple of minutes, you're already itching and swelling. But with poison ivy and poison oak, it will actually take a day or two before you actually get that red rash. And it's also, you can spread it because it's an oil. So if you touch other parts of your body with, like if you touch the leaf with your hand and then you scratch your face and touch other parts of your body, you can spread it before you realize. Sometimes jewelry or cosmetics can cause this delayed hypersensitivity reaction as well. Right? So, but the most classic type of type 4 hypersensitivity is having to do with transplant tissues. So rejecting a graft, or in some cases the grafted tissue can reject the host. So graft rejections are when you get like an organ transplant and your T cells recognize that, let's say that you got a kidney transplant, and the kidney's from someone else, and they have different MHC class 1, different self markers, and your T cells recognize it as not self. And so then the T cells end up killing those kidney cells and killing that kidney. That's graft rejection. But there's another thing called graft versus host disease. So graft rejection is called host versus graft. The host rejects the grafted tissue being the kidney. But sometimes you will transplant tissue that contains immune cells from another person. The most classic one are bone marrow transplants. Bone marrow contains the stem cells for all of your red and white blood cells. All right, so basically, if you got a bone marrow transplant and those T cells from the bone marrow of the person you got it from, like let's say you got it from someone named Bob, all right, so now Bob's T cells and immune cells find themselves in a foreign environment, and they look around and they're like, this is not Bob's, these are not Bob's cells, and they just start attacking everything. So graft versus host disease can be pretty serious because it's not just attacking one organ or tissue, it can attack many because it recognizes all cells as foreign when really they are the foreign cells, but their job is to attack things that are not like themselves. So that's the difference between host versus graft and graft versus host disease. So these, when you have a graft or a tissue transplant or an organ transplant, there's many different ways they can do it. So you can get like a skin graft. I think I told you guys the story before when I got bit by a brown recluse spider in college on my leg, and the doctor told me I might need a skin graft, all right, because it causes necrosis, and sometimes people get other infections and then they get a large lesion. But I did not need a skin graft. It was all good. But if I did, they probably would have just taken skin from another part of my body and grafted it. So that's called an autograft, all right, when they just take something from another part of your body. And so it's totally you. It's all self. There's no issue with rejecting anything that's from you. The second best thing to that is getting a graft from an identical twin, because identical twins have the exact same genetics. So they're going to have the same MHC markers, and so those will be very well received, though the body will not be able to identify that those are non-self. So autograft and isograft are the best way to go, but not everybody has an identical twin. And there are certain parts of your body you can't autograft. If you have failing kidneys, you can't donate yourself a kidney. So then usually you need to get grafts from other people, usually relatives, but sometimes not. And especially if it's a vital organ, then it's definitely not a relative. It's usually someone who has passed unexpectedly, often in another state, and who is a good match, who just happens to have enough of those matches of their MHC markers. Remember, the MHC is the self marker, the MHC class 1. And so we all have multiple types of MHC class 1, but if you have someone who has enough matches to you, then they're a good potential donor. There's also some tissues that can come from animals. We call those xenografts. So allo means like different, another. So an allograft is from another person. Xeno means foreign or stranger. So think of like animals are really foreign to human tissues. But you can do like a lot of valves are like pig or cow valves for heart valve replacements. I'm not really sure about all the other, about a whole bunch. I'm not sure there's any actual orangutan transplant tissues. Alrighty, so we're still talking about hypersensitivities, overactive immune responses. And we can also call these things autoimmunity. So there's a whole slew of diseases, of chronic diseases, where the body is attacking itself, some part of itself. I don't even know how many different autoimmune diseases, but they can be localized to different body systems. So you can have people who have type 1 diabetes. Their immune system attacks specific cells in the pancreas that produce insulin, so they can't produce insulin anymore. People with inflammatory bowel disease or celiac disease have inflammation specifically in the gastrointestinal system. Psoriasis is an autoimmune disease of the skin. So there's autoimmune diseases of different body systems, and then there's also ones that are sort of more systemic, like lupus, which is also called SLE, systemic lupus erythematosus, which has more systemic, affects a lot of parts of the body, particularly the joints, but also the organs. And they can fall under different types of hypersensitivities. So lupus is a type 3 hypersensitivity. It's due to IgG antibodies that cause these like clumps of antigen antibody to form in different tissues. All right, but rheumatoid arthritis can be type 1, type 2, type 3, or type 4. Type 1 diabetes is type 4. It is due to T cells that are killing certain cells in the pancreas. So different autoimmune diseases, although the thing they all have in common is that your immune system is attacking you, some part of you, they are all very different in their mechanisms. Some of them involve antibodies and are antibody mediated, and some of them are T cell mediated. So the study of autoimmunity is really a complicated field. Every autoimmune disease, and even every person who has lupus, may have very different presentations. Okay, so people who are susceptible to autoimmune diseases, part of it is due to genetics, so autoimmune diseases tend to run in families. Again, it might not be the same autoimmune disease. So my step family, actually I've got a stepsister with Crohn's disease, and her first cousin has lupus, and I think they have another cousin who has rheumatoid arthritis. So it does seem like in her paternal family there is some genetic predisposition to autoimmune diseases, even though they all have something different. They all happen to be female, and females are more likely to develop autoimmune diseases. Still not totally sure why that is. And then it also might be due to microbes. We see, for example, with rheumatic fever, after strep infection, the body can start making antibodies that are supposed to target the strep, but they target a part of the strep that looks a lot like a cardiac protein, and then you start basically making antibodies that attack the heart. That's sort of an autoimmunity that's triggered by microbes. And so there's a lot of these autoimmune diseases are thought to maybe be triggered by microbes, some microbe, virus or bacteria that has a part that looks very similar to some part in our body, and when we mount an immune response to it, we unfortunately also end up mounting this unintentional immune response towards that part of our body. So I think it's an adenovirus that they think might be the trigger for type 1 diabetes. So I think in the next decade or so, with microbiome research and more research of the microvirome too, we might start finding more viruses or bacteria that are actually causes that trigger autoimmune diseases. Alrighty, so we just spent an hour talking about hypersensitivities, so overreactions of the immune response, allergies, autoimmune diseases, and some of those other types of hypersensitivities. But the other side of immunopathology is hyposensitivity, not sensitive enough, or immunodeficiency. And immunodeficiencies can happen one of two ways. You can either basically be born with it. We call that a primary immunodeficiency, so something genetic or congenital. And then, or there are immunodeficiencies that you can develop over time, usually as a result of medication or of an infection, and we call those secondary immunodeficiencies. So primary immunodeficiencies, well, we'll talk about them. Okay, so primary immunodeficiencies. I'll move my head down here. The three that we're going to talk about are having a B cell deficiency, having a T cell deficiency, or having a total B and T cell deficiency. So B cell deficiency, remember B cells are important for making antibodies or immunoglobulins. The most important immunoglobulin being IgG, or immunoglobulin gamma is what the G stands for. Okay, so I'm just telling you that because that's where this name, A-gamma globulinemia, comes from. It's a big mouthful of a word, but it literally means without gamma globulin, or IgG, in the blood. It says people who don't have B cells can't make antibodies. Any of them really, but it's called A-gamma globulinemia. And so people who can't make antibodies, they have a really hard time fighting off bacterial infections because antibodies are sort of the main line of defense for bacterial infections. We don't use a lot of cell-mediated immunity for bacteria. We use a lot of cell-mediated immunity for viral infections, so the T cells can still take care of viruses, but we don't have antibodies to kill those bacteria. So antibiotics help, but also if they need them, sometimes they can get infusions of antibodies from other people, like from people who donate blood. You can extract the serum and all the antibodies from the blood, and you can inject it in these people with B cell deficiency, I don't know, once a month or something, to give them passive immunity so that they have some antibodies circulating in their blood if they need them. And that can help protect them, prevent sort of prophylactic, but can also be given in the case of a specific infection as well. People with T cell deficiency, T cells kill virus-infected cells, so they're more susceptible to viral infections. But also they're more susceptible to cancer because T cells are also important for killing cancer cells. So one way that you can have a T cell deficiency is you can be born without a thymus or with a non-functioning thymus, and this is called DiGeorge syndrome. Remember, the thymus is where immature lymphocytes go to develop into T cells. So without a thymus, you only have B cells. And there is such a thing as a thymus transplant, and that can help in the case of DiGeorge syndrome. And then lastly, there's a set of there's some different diseases, there's different forms of this disease that result in B and T cell deficiencies, and we call them SCID, or severe combined immunodeficiency. It's severe because you have a loss of the combination of B and T cells. And there's, like when you hear medical stories about this, they often refer to these individuals as like bubble boy, because they basically have to like live in a sterile bubble. They are so so susceptible to all kinds of infections because they basically lack an adaptive immune system. All they have is their innate immune system. They can't be vaccinated because they won't make any immune memory. And they have to be basically kept very, very sterile, low exposure to pathogens, and they have a shortened lifespan because of it. It's nearly impossible to keep them free of infection forever. There is some evidence, though, of treatment of SCID, both with bone marrow transplant, and now we're seeing some cases of treatment with gene therapy, like using CRISPR to edit that the mutated gene so that it's functional, so that they can make functional B and T cells. But bone marrow transplants have been effective as well, basically giving people new stem cells to make B and T cells from. And this is just a slide graphically showing you these different types of diseases. Remember, all of your blood cells come from the bone marrow. So here's a stem cell, a lymphoid stem cell for the lymphocytes. It can turn into either B cells or T cells. To become a T cell, that little immature cell needs to go to the thymus. So if you don't have a thymus, then you get DiGeorge syndrome and you don't get T cells. If the B cell doesn't mature properly in the bone marrow, then you won't get mature B cells and you end up with agamma-globulinemia or hypogammaglobulinemia. You just don't make any or enough antibodies. And this shows you which scenario, which types of infections you're more prone to. If you don't have B cells, you're much more prone to bacterial infections. If you don't have T cells, you're going to be more prone to fungal and viral infections. Now, there are also things that can cause a healthy person to become immunodeficient. We call those secondary immunodeficiencies. They can be natural, so they could be caused by infection. HIV, human immunodeficiency virus, is the classic one. It infects T cells. So it infects your white blood cells and kills them. So it literally attacks and kills your immune system, which makes you immunodeficient. Measles is also a classic one. Measles actually, even once if you've fought off measles, if you've gotten sick with measles and you fought it off, it actually depletes your immune system and it somehow miswires them. It kills like memory cells. So for a couple of years after recovering from measles, you are actually immunodeficient and more prone to all kinds of other infections. Different organic diseases. If you have a disease that affects any of your lymphatic tissue, if you have bone cancer, or if you're a thymoma, your thymus has cancer of the thymus, or your lymph nodes, any of those types of blood or lymphatic cancers make you immunodeficient. But also other cancers can be treated with drugs that kill your immune system. So chemotherapy for cancer, cancer chemotherapy generally works very non-specifically. It doesn't oftentimes, there are some kinds now that target specific cells, like there are some drugs specifically to target certain types of breast cancer. But a lot of chemotherapy agents are basically just toxins that target fast metabolizing and fast dividing cells, which cancer cells are. So it will preferentially attack cancer cells, but also your hair follicle cells divide very quickly, your gastrointestinal lining divides very quickly, and your immune cells divide very quickly. So all of those are sort of collateral damage of some of these chemotherapeutic agents. So while they're killing cancer cells, they're killing those other cells as well, including your white blood cells. So cancer chemotherapy does weaken the immune system. Transplant patients, people who've had a transplanted organ, unless it's from an identical twin, it was not a perfect match. It was hopefully a good match, but not a perfect match. And so people who have transplants need to be on immunodepressants or immunosuppressant drugs to suppress their immune system so their immune system doesn't recognize that transplanted organ as foreign and start attacking it and rejecting it. And then another type of treatment of cancer that can deplete the immune system is radiation. It similarly is not very specific. It targets any cells in its wake, basically, including your immune cells. Oh, and so that's the end. I just want to go back real quick to these hypersensitivities. And after you have maybe got a better understanding of the whole thing, this is a good slide to review, sort of to make sure that you understand the differences in the mechanisms that are involved in each of these types of responses. That's a key thing to know with the different hypersensitivities. There's many more types of hypersensitivity than there are hyposensitivity or immunodeficiencies. That is the end